Hi, and welcome to the lecture on chest injuries, chapter 27 in your text. After you complete this chapter and related coursework, you will understand how to manage a patient with chest trauma. You will learn how to recognize life threats associated with these injuries and how to provide immediate intervention. The curriculum includes a detailed description of the anatomy and physiology of the chest and the underlying organs, as well as the pathophysiology, complications, assessment, and management of chest injury. Age-related issues are discussed specific to pediatric and geriatric chest trauma. This chapter also provides information on incidents as in morbidity and mortality, and a detailed discussion of blunt versus penetrating or open trauma. Specific injuries discussed include sucking chest wounds, pneumothorax, tension pneumothorax, hemothorax, flail chest, and pericardial tamponade. The National EMS Education Standard Competencies for Trauma state that the EMT will apply the fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. Regarding chest trauma specifically, you will recognize and manage blunt versus penetrating mechanisms of injury, open chest wounds, and impaled objects. You will understand the pathophysiology and be able to assess and manage patients who have blunt versus penetrating mechanisms and hemothoraxes, as well as pneumothoraxes, open, simple, and tension, cardiac tamponade, rib fractures, flail chest, and commodio cordis. Chest trauma cases count for more than 700,000 emergency department visits and more than 18,000 deaths in the United States annually. They can involve the heart, the lungs, and the great vessels. EMTs must treat any injuries that interfere with the body's mechanics of normal breathing without delay. Internal bleeding can collect in the chest cavity and it can compress the lungs or the heart, and air may collect in the chest and prevent the lungs from expanding. Ventilation is the body's ability to move air in and out of the chest and lung tissue. Injuries affecting the patient's ventilation are serious and may be life-threatening. Respiration is the exchange of gases in the alveoli of the lung tissue, and this includes the delivery of oxygen and the removal of carbon dioxide. The chest, or the thoracic cage, extends from the lower end of the neck to the diaphragm. A penetrating injury to the chest may also penetrate the lung and diaphragm and injure the liver or stomach. Thoracic skin, muscle, and bones have similarities to skin, muscle, and bones in other regions. Unique features such as striated or skeletal muscle allow for ventilation. Intercostal muscles extend between the ribs, and they are not yet developed in very young children who tend to breathe from the diaphragm or who are belly breathers. Innervations occur from the spinal nerves, and this allows the chest to expand on contraction and the active portion of ventilation to occur. The neurovascular bundle is a network of nerves and arteries as well as veins lying closely along the inferior of and slightly posterior to the lowest margin of each rib. They can be a source of significant bleeding into the pleural space. The pleura covers each of the lungs and the thoracic cavity. The parietal pleura is the inner chest wall lining. The visceral pleura covers the lung, and surfactant, which is the fluid that is between the parietal and visceral pleura, allow the lungs to move freely against the inner chest wall as a person breathes. The ribs are connected in the back to the vertebrae and in the front to the sternum. The thoracic cage also contains the heart and the great vessels, the aorta, the right and left subclavian arteries and their branches, the pulmonary arteries, and the superior and inferior vena cava. The mediastinum is the central part of the chest containing the heart, great vessels, esophagus, and trachea. A thoracic aortic aneurysm occurs when a weakened portion of the aorta wall develops a false lumen that eventually ruptures and causes fatal hemorrhage into the thorax. The diaphragm is a muscle that separates the thoracic cavity from the abdominal cavity. The intercostal muscles, which are the muscles between the ribs, contract during inhalation. The diaphragm contracts at the same time, and the inner thoracic pressure inside the chest decreases, which creates a negative pressure differential. Air then enters the lungs through the nose and mouth. The intercostal muscles and diaphragm relax during exhalation, and this allows air to be exhaled. The body should not have to work to breathe when in a resting state. And this animation shows what we were just talking about. A patient whose spinal cord is injured below the C5 level will lose the power to move the intercostal muscles. The diaphragm will still contract, and the patient will still be able to breathe because the phrenic nerve remains intact. Patients who have a spinal injury above C3 may lose the ability to breathe. Minute ventilation, or minute volume, is the amount of air moved through the lungs in 1 minute. It is calculated by multiplying normal tidal volume by the patient's respiratory rate. Patients with decreased tidal volume will have an increased respiratory rate. A 1,000 to 1,500 milliliter bag mask device might overinflate the lungs, causing gastric distension and impaired lung function. Rapid respirations can cause acid-base imbalance and blood gas imbalance. There are two types of chest injuries, open and closed. In closed chest injuries, the skin is not broken. These types of injuries are generally caused by blunt trauma. They often cause significant contusions in cardiac muscle, called cardiac contusions, and lung tissue, called pulmonary contusions. If the heart is damaged, it may not be able to refill with blood, or blood may not be able to return to it, and this will result in cardiogenic shock. Lung tissue bruising can result in exponential loss of surface area with decreased oxygen and carbon dioxide exchange, and this can cause hypoxic and hypercarbic states. Rib fractures can lacerate lung tissues and cause further vessel damage with every chest wall movement, and this can rapidly lead to hypovolemic shock. In open chest injuries, an object such as a knife, bullet, piece of metal, broken end of a fractured rib, or other items or objects may penetrate the chest wall itself. They cause instant damage, but symptoms develop over time. An impaled object will remain in place, and you should not attempt to move or remove it. It may be occluding the hole in a punctured vessel, and removal may cause heavy bleeding, and it can also cause additional damage during the removal process. Blunt trauma to the chest may cause a fracture of the ribs, fractured sternum, or injury to the chest wall. It can bruise the lungs and the heart and even damage the aorta. Almost 1/3 of people killed immediately in car crashes die as a result of traumatic rupture of the aorta. Vital organs can also be torn from their attachment in the chest cavity, causing internal, life-threatening bleeding. The signs and symptoms of chest injury include pain at the site of the injury, pain localized at the site of the injury that is aggravated by or increased with breathing. An irritation of or damage to the pleural surfaces causes sharp or sticking pain with each breath, and this is called pleuritic type pain or pleurisy. Bruising to the chest wall, crepitus with palpation of the chest, any penetrating injury to the chest, dyspnea, which is difficult breathing or shortness of breath, and this can be caused by airway obstruction, damage to the chest wall, improper chest expansion, or lung compression. Prompt, vigorous support of oxygenation and ventilation with prompt transport are required. Hemoptysis, or coughing up blood. This indicates damage to the lung or air passages. Failure of one or both sides of the chest to expand normally with inspiration. Rapid, weak pulses and low blood pressure. This is a principal sign of hypovolemic shock, and it can result from extensive bleeding of the lacerated structures within the chest cavity or an insignificant oxygenation of blood. Cyanosis around the lips or fingernails, which is a sign of inadequate respiration, and immediate ventilation and oxygenation are required at this time. Patients with chest injuries often have tachypnea, which is rapid respirations, and shallow respirations because it hurts to take a deep breath. The patient may not actually be moving air due to chest wall trauma, and you should auscultate multiple locations on the chest wall to assess for adequate breath sounds. For patient assessment steps, they're always the same: scene size up, primary assessment, history taking, secondary assessment, and reassess. Regarding scene safety, you should observe for hazards and threats to the safety of the crew, bystanders, and the patient. If the area is a crime scene, do not disturb evidence. Request law enforcement for scenes involving violence, such as assaults or gunshot wounds, and if needed, call for the power company, fire department, or ALS units early. At a minimum, use gloves and eye protection. Evaluate your mechanism of injury and nature of illness. Chest injuries are common in motor vehicle crashes, falls, and assaults, and you need to determine your number of patients. You should always consider the need for spinal immobilization. Form your general impression. Note your patient's level of consciousness, perform a rapid scan, looking for obvious injuries, appearance of blood, difficulty breathing, and cyanosis, as well as irregular breathing. Look for chest rise and fall on only one side, accessory muscle use, and extended or engorged external jugular veins. Assess the airway, breathing, and circulation, which is the ABCs. Also assess the patient's overall appearance and ask, how sick is this patient? Airway and breathing, you should ensure that the patient has a clear and patent airway. Consider early cervical spine stabilization and note whether the jugular veins are distended. Signs of pressure or tamponade on the heart may result from a tension pneumothorax and also may result from injury to the heart, allowing bleeding into the pericardium, and we call this pericardial tamponade. You need to determine whether breathing is present or adequate and inspect for decap BTLS. Look for equal expansion of the chest wall. Remember that unequal expansion indicates loss of muscle function. It may be due to a direct injury to the chest wall, or it may be related to an injury of the nerves controlling those muscles. You should check for paradoxical motion and abnormality associated with multiple fractured ribs. Address this abnormality immediately by using a gloved hand to stabilize a flail segment or occlude an open chest wound. Stabilize using a large bulky dressing and apply occlusive dressings to all penetrating injuries to the chest. Support ventilations, apply oxygen via a non-rebreather mask at 15 liters a minute, and if breathing is inadequate, provide positive pressure ventilations. Do not use for patients with a pneumothorax. Continue to auscultate breath sounds and reassess the effectiveness of ventilatory support, and be alert for decreasing oxygen saturations. This can lead to hypoxia, and you should be alert for impending pneumothorax, for example, increasingly poor compliance during ventilation. Assess circulation. You assess the pulse and determine whether it is present and adequate. If the pulse is too fast or too slow, or if the skin is pale, cool, or clammy, consider your patient to be in shock. Address life-threatening bleeding immediately using direct pressure and a bulky trauma dressing. Make your transport decision. Priority patients are considered patients who have a problem with their airway, breathing, or circulation, and you need to pay attention to subtle clues such as the appearance of the skin, level of consciousness, whether the patient has a sense of impending doom, and remember, a delay on the scene to perform a lengthy assessment will reduce the chances of your patient's survival. With chest injuries, when in doubt, perform rapid transport. There are, in the chest injury guidelines, a list of a dozen injuries that are considered deadly for chest trauma patients. These are generally immediately life-threatening, and they must be detected and managed during a primary assessment. They are airway obstruction, bronchial disruption, diaphragmatic tear, esophageal injury, open pneumothorax, tension pneumothorax, massive hemothorax, a flail chest, cardiac tamponade. And the last three are potentially lethal that may be identified during your secondary assessment, and they are a thoracic aortic dissection, a myocardial contusion, or a pulmonary contusion. Take your history. Investigate the chief complaint and further investigate the mechanism. Identify associated signs and symptoms and pertinent negatives. Verify where the pain is located in relationship to an area being touched. Pertinent negatives when examining the chest include no associated shortness of breath, no rapid breathing, no absent or abnormal breath sounds, no areas of deformity or abnormal movement, and equal expansion of the chest and movement of the rib cage and the diaphragm, and this can confirm to you that there is nerve conduction to that region of the body. Start on your sample history and focus on the mechanism again, and then also look at signs and symptoms, allergies, medications, pertinent medical problems including respiratory or cardiovascular disease, last oral intake, events leading up to the emergency. And remember, your questioning should focus on the MOI. How fast was the vehicle going, or how high was the fall? Did they use any safety equipment? Were there any types of weapons involved? And how many penetrating wounds are present if there are penetrating wounds? For your secondary assessment in your physical exam, you need to perform a full-body scan. If the injury is isolated with a limited mechanism, you can focus on the isolated injury, the patient's complaint, the body region that was affected, the location and extent of the injury, the anterior and posterior aspects of the chest wall, and be alert for changes in the patient's ability to maintain adequate respirations. For significant trauma, use DCAP BTLS to determine the nature and extent of the thoracic injury, and also quickly assess the entire patient from head to toe. Performing vital signs should be included, and this is including an assessment of pulse, respirations, blood pressure, skin color, temperature and condition, and pupils. You should reevaluate your patient every 5 minutes or less. A rapid pulse or respiratory rate may indicate that the chest injury is causing a decrease in available oxygen, known as hypoxia, or blood loss, resulting in decreased red blood cell count, hypoxemia. Increased work of breathing can be identified by the use of accessory muscles in the face, neck, and chest. Pulse and respiratory rates may decrease in later stages of chest injury, and the myocardium becomes starved for oxygen and the body can no longer keep up with the demands. The brain becomes starved for oxygen and overloaded with carbon dioxide and other waste products, and you must use appropriate monitoring devices. The pulse oximeter establishes a baseline measurement and helps you recognize any downward trends indicating that a patient's condition is worsening. Repeat your primary assessment and reassess the chief complaint, including airway, breathing, pulse, perfusion, and bleeding. Perform your interventions and provide complete spinal immobilization for patients with suspected spinal injuries. Maintain an open airway. Be prepared to suction the patient. Consider an oral or nasal airway. Control significant visible bleeding and provide high-flow oxygen, and place an occlusive dressing over any penetrating trauma to the chest wall. You should manually stabilize a flail segment using a bulky dressing. You should avoid increasing the patient's work of breathing and pain, and you should be prepared to provide positive pressure ventilations. For patients with signs of hypoperfusion, you will need to provide aggressive treatment for shock and rapid transport. You should not delay transport to complete non-life-saving treatments. These can be performed en route to the hospital. Communications and documentation. You need to communicate all relevant information to the staff at the receiving hospital and describe all injuries and the treatment given. Next, we're going to talk about some complications and management of chest injuries, and the first one we're going to talk about is a pneumothorax. It's commonly called a collapsed lung, and it describes an accumulation of air in the pleural space. Air enters through a hole in the chest wall or surface of the lung, and the patient's attempts to breathe cause the lung on that side to collapse. Blood passing through the collapsed portion of the lung is not oxygenated, and breath sounds on the affected side of the chest indicate different conditions. If the lung is collapsed past 30 to 40%, you may hear diminished breath sounds. Absent breath sounds may indicate attention pneumothorax. A sucking chest wound or a sucking sound on inhalation and the sound of rushing air on exhalation indicate that the chest wall has been penetrated. And here's an example of a pneumothorax. You can see that the lung on the left side of the screen is collapsed, much smaller in the lung space than the one on the right side of the screen. An open chest wound is called an open pneumothorax or a sucking chest wound. After clearing and maintaining a patient's airway, these wounds must be rapidly sealed with a sterile occlusive dressing. The dressing prevents air from being sucked into the chest through the wound, and Vaseline gauze and aluminum foil are examples of sterile materials used for such a dressing. And this is an example of an open pneumothorax or a sucking chest wound. You see air in and air out through the penetrating part of the chest.
Open chest and back wounds can be life-threatening if they involve the lungs, large vessels, or heart. Cover these wounds with an occlusive dressing, which is a dressing that's designed to be airtight. It can be made from a variety of materials, such as plastic wrap, aluminum foil, or a special dressing impregnated with petroleum jelly. Occlusive dressing should be secured to the body with tape on 3 sides, leaving the 4th side open to allow trapped air to escape the chest cavity. Open abdominal wounds are serious too. Apply a dry, sterile dressing, keep the patient warm, and place the patient on his or her back with legs elevated. If the patient is having difficulty breathing, place them in a semi-reclining position instead. Don't try to push protruding intestines back inside the abdomen.
Okay, the first part of the video was the flutter valve, and this is a one-way valve that allows air to leave the chest cavity but not return. If one is used, you tape it only on 3 sides of the occlusive dressing. After applying the dressing, carefully monitor the patient for signs of developing a tension pneumothorax. If a tension pneumo develops, the dressing will need to be partially removed, and you should consult your local protocols and manufacturer's guidelines. A spontaneous pneumothorax is caused by structural weaknesses rather than trauma. The weak area is called a bleb, and it will occasionally rupture spontaneously, allowing air to leak into the pleural space. It is due to normal breathing or during times of strenuous physical activity. The patient experiences sudden sharp chest pain and increasing difficulty breathing, and a portion of the affected lung collapses. You should suspect a spontaneous pneumo in patients who experience sudden chest pain and shortness of breath without a specific known cause. Some of the possible signs and symptoms include decreasing breath sounds on the affected side, which is a collapse greater than 40%, increased respiratory rate and work of breathing, hyperinflation on the injured side, hemothorax due to air trapped in the pleural space. Pre-hospital treatment includes administration of oxygen and transport, and be alert for signs of a developing tension pneumo and consider the need for an ALS intercept. A simple pneumo does not result in major changes in a patient's physiology. This type of injury is commonly the result of blunt trauma that results in fractured ribs. You will hear decreased breath sounds associated with significant lung collapse. Signs and symptoms include dyspnea, increased work of breathing, and increased respiratory rate, tachypnea and accessory muscle use, and decreased oxygen saturation. Late findings include decreased breath sounds on the injured side, lethargy, and cyanosis. And you should be vigilant because the simple pneumo can often worsen or deteriorate into a tension pneumo or develop complications like bleeding and hemothorax. Pre-hospital treatment is to provide high-flow oxygen, monitor oximeter readings and breath sounds, treat the underlying cause of the injury, and do not withhold positive pressure ventilation if the patient needs support. It may cause a tension pneumo, and you should have a plan to resolve the complications. A tension pneumothorax results from significant air accumulation in the pleural space. This air greatly increases the pressure in the chest, causing a complete collapse of the unaffected lung. The mediastinum is to be pushed in the opposite pleural cavity, and blood then cannot return to the vena cava in the heart. You will have decreasing cardiac output, and this leads to shock and ultimately will result in death. It is commonly caused by blunt injury in which a fractured rib lacerates a lung or the bronchus. You can see here the signs and symptoms that are normally seen. So first of all, you're going to have increased respiratory distress, altered level of consciousness, distended neck veins, deviation of the trachea to the side of the chest opposite the tension pneumo. You can see here in the picture, right here, the trachea is no longer midline, it's starting to push off in this direction. Tachycardia, low blood pressure, and cyanosis. You'll also have decreased breath sounds on the side of the tension pneumothorax, as you can see here. Pre-hospital treatment includes providing high-flow oxygen, requesting ALS support or transport immediately, and needle decompression to be performed by ALS personnel or emergency department staff, depending on your local protocols. A hemothorax is a condition in which blood collects in the pleural space from bleeding around the rib cage or from the lung or great vessel. Here you can see blood-filled pleural space, also blood-filled pleural space here. This is a hemopneumo because you've got blood and air. This is the hemo, which is completely blood. And this animation shows that this is coming from a major vessel and is filling up the lung. The signs and symptoms that we see generally are signs and symptoms of shock and decreased breath sounds on the affected side. The lung is being compressed by the blood. Pre-hospital treatment for this condition includes the realization that we cannot control this internal bleeding in the pre-hospital setting, and we must provide rapid transport to the nearest facility capable of performing surgery. The presence of air and blood in the pleural space is known as a hemopneumothorax. Cardiac tamponade. Cardiac tamponade or pericardial tamponade occurs more commonly with penetrating chest trauma, although it may occur in blunt trauma. The protective membrane around the heart, the pericardium, fills with blood or fluid like pus. The heart then cannot pump an adequate amount of blood. You can see here the normal heart on the left, and then the pericardial tamponade heart on the right, where the heart will no longer be pumping effectively because of the space restrictions. Signs and symptoms include Beck's triad. Beck's triad, and you need to know this, is distended or engorged jugular veins seen on both sides of the trachea, a narrowing pulse pressure, and muffled heart sounds. You will also see altered mental status due to decreased blood flow to the brain. Pre-hospital treatment involves supporting ventilations with positive pressure ventilations if needed, but know that they can pose a risk of hypoventilation, and rapid transport to a facility capable of intervention. Rib fractures are very common, particularly in older people whose bones are brittle. A fracture of one of the upper 4 ribs is a sign of a very substantial mechanism of injury. A fractured rib may lacerate the surface of the lung, causing a pneumothorax, a tension pneumothorax, a hemothorax, or a hemopneumothorax. Crepitus, or subcutaneous emphysema, is a crackly feeling in the area of the injury underneath the skin. Signs and symptoms include localized tenderness and pain when breathing, rapid shallow respirations, and the patient holding the affected portion of the rib cage. Pre-hospital treatment includes supplemental oxygen. Young pediatric patients have a more flexible rib cage, and the organs beneath the rib cage may be injured even if the rib cage is not fractured. A flail chest is caused by compound rib fractures that detach a segment of the chest wall. The detached portion of the chest will move opposite of normal. Will move in during exhalation and out during inhalation. Pre-hospital treatment includes maintenance of the airway, providing respiratory support if needed, and giving supplemental oxygen. You should reassess for possible pneumothorax or other respiratory complications. To immobilize a flail segment, you can tape a bulky dressing or pad against the segment of the chest, or you can put your gloved hand there. Splint the chest with a pillow that the patient can hold against the chest wall. Do not use anything heavy. Flail chest may indicate serious internal damage and possible spinal injury. Pulmonary contusion should always be suspected in a patient who has a flail chest. The pulmonary alveoli become filled with blood and fluid accumulates in the injured area, leaving the patient hypoxic. Pre-hospital treatment includes providing respiratory support and supplemental oxygen. Other fractures. Sternal fractures require a significant amount of force, and there should be an increased index of suspicion for injuries to underlying organs like the lungs, the great vessels, and the heart. Clavicle fractures are covered under skeletal injuries, and we'll talk about those in more detail then. You do need to realize there's a significant damage or disruption to the large neurovascular bundle it protects, and that's possible to cause additional issues for your patient. You should suspect upper rib fractures and medial clavicle fractures and be alert to possible signs of pneumothorax development. Traumatic asphyxia. It's characterized by distended neck veins, cyanosis in the face and neck, and hemorrhage into the sclera of the eye. It describes sudden severe compression of the chest, which produces a rapid increase in pressure within the chest. An example would be an unrestrained driver who hits the steering wheel. It suggests an underlying injury to the heart and possibly a pulmonary contusion. Pre-hospital treatment includes providing ventilatory support with supplemental oxygen and monitoring vital signs during immediate transport. Blunt myocardial injury is bruising of the heart muscle. Blunt trauma may injure the heart itself, making it unable to maintain adequate blood pressure. Signs and symptoms include an irregular pulse rate, and remember, ventricular tachycardia and ventricular fibrillation are common. The patient may complain of chest pain or discomfort, and that's similar to cardiac symptoms. You should suspect myocardial contusion in all cases of severe blunt injury to the chest, and pre-hospital treatment involves monitoring the patient's pulse carefully and noting any change in blood pressure. Commotio cordis. Blunt chest injury caused by a sudden direct blow to the chest that occurs only during the critical portion of a person's heartbeat. The result may be immediate cardiac arrest. This phenomenon has been documented to have occurred after patients were struck with softballs, baseballs, bats, snowballs, fists, and kicks. The resulting VFib responds positively to defibrillation within the first 2 minutes of the injury. Laceration of the great vessels. This may be accompanied by massive, rapidly fatal hemorrhage. The great vessels include the superior vena cava, the inferior vena cava, the pulmonary arteries, the 4 main pulmonary veins, the aorta and its major branches. Pre-hospital treatment includes ventilatory support if needed. immediate transport, remaining alert to signs and symptoms of shock, and closely monitoring changes in baseline vital signs for signs of tachycardia or hypotension. In summary, a penetrating chest injury has the potential to penetrate the lung and diaphragm and to injure the liver or stomach. Closed chest injuries are often the result of blunt force trauma, and open injuries are the result of some object penetrating the skin or the chest wall. Blunt trauma may result in fractures to the ribs and the sternum. Injuries that interfere with the ability of the patient to ventilate or oxygenate must be addressed quickly. Penetrating injury to the chest may allow air to enter the pleural space, causing pneumothorax. Cover the wound with an occlusive dressing. A penetrating injury that creates a hole in the chest wall is called an open pneumothorax or a sucking chest wound. A spontaneous pneumothorax may be the result of rupture of a weak spot on the lung, allowing air to enter the pleural space and accumulate. A simple pneumothorax is a result of blunt trauma resulting in fractured ribs. A pneumothorax may progress to a tension pneumothorax and cause cardiac arrest. Hemothorax is the result of blood accumulating in the pleural space, and a hemopneumothorax is the presence of air and blood in the pleural space. A flail chest segment, two or more ribs broken in 2 or more places, should be immobilized with a large bulky dressing. All patients with severe chest injury should receive high-flow oxygen or ventilation with a bag mask device. Pulmonary contusion, which is bruising of or injury to lung tissue after traumatic injury, may interfere with oxygen exchange in the lung tissue. Traumatic asphyxia is sudden severe compression of the chest, and myocardial contusion describes bruising of the heart muscle. Thanks for your attention, and as always, bring any questions you may have to class to discuss with your instructor.